respected judges and dear friends. Mine is very simple study to done on the what are the problems faced by a resident during DCR. There is no financial interest. As we all know that DCR is the prominent cause of ocular morbidity in India and almost the most common cause for the EP4A. External DCR remains a gold standard treatment for all of the time since more than 100 of years everyone is doing this, and the success rate of DCR varies from 82 to 99% in various studies and there. But why we plan this study is very much important. Most important is that when we search the PubMed literature and other thing, then there is no such big studies or any studies who have find out the these surgical outcomes are the complications reported by only the trainee, not by the experts. And second one is each and every places, even our teachers and teachers can guide. If you do lot of DCRs or good surgery, no, like huge number of surgery, your results will be better, complications will be less. But what is the number? How much number is needed for a PG curriculum or anywhere to say that if anyone can do such a number of cases or such a number of things, he or she have some better things. Like in our residency, we are told by our teachers at least do 15 suturing on gloves, then come to us for that. Similarly, this study is planned. If we got any number or significant number in future, then we can recommend that at least in the residency training program we have such a number of cases given to first year, second year, or third year. With this aim we started this study, and the objective I've already mentioned. It was a cross-sectional observational study done in the duration of almost 1 year, October 21 to 20 to September 22. We have taken the institute ethical clearance for this. Inclusion criteria almost standard. All the patient attending our OPD and having indications for the DCR surgery. We excluded the complicated cases, failed DCRs or the another DCRs. For that, only the primary DCRs were given. And a questionnaires we prepared for all the residents, which we have given. We have quantified 7-8 major steps in the DCR surgery process. Which step is important and which we can go. Assessment, all the patients were assessed as per the guidelines of our own hospital, and the DCR protocol is being followed. All the steps of the surgical steps, whatever is the things needed, prescribed in the traditional books, and when all done into the same way. There is no change in it. The data we got analyzed by the SPSS software, and p-value is considered as to find out any significant improvement is there or not. So I'm coming to my results and observation. Total 35 responses we obtained from the junior residents, 30 from junior resident and 5 from our senior resident. All residents belong to the age group of 25 to 34, and 11 were male and rest female. Among the 30 junior residents, 10 were from the first year, 10 second year, and 10 third year, and 5 SRs. We clubbed them, these 5 SRs, they are just completed the third year, into the third group to find out the responses. And here is this response. We have given almost 10 to 15 surgeries in each groups, so that the first year should get 20 surgeries, 15 to 20, then third in the second years they will become 30 to 70, and in the third year become 80 to 120 surgeries, so that we know how many surgeries they perform to reduce the rate. This is the problem, most common problems faced by the all residents. They are saying one problem is there. In the problem of the first year, we have seen the planning, angular vein management, and suturing. Second year have different type of problems. Are they all these the problems they are facing? And here we quantify each and every problem. Means in the first year is having incision, angular vein management, and nasal packing problem, which is almost obsolete after in the second year or third year residents. Means after doing 15 to 20 surgeries. But the problems with bone punch and nasal mucosa still persist in the second year. Means after 30 surgery or 25 surgery, these problems will reduce, because none of the third year have such type of problems. But again, I am saying the cosmetic related issues or suturing of mucosal flap, these are something which is although its number reduced almost 60% from 10 to 4 or 10 to 6, but it is again faced by the third year. So when we calculated whether it is significant or not, then all the steps, second years having better result and lesser complication when we compare to the first year, even third year having lesser complication when compared with second year, and third year and first year definitely have a greater p values. So coming to the discussion, we find out that anatomical success rate in our study is much better in the third years who have performed at least 80 surgeries. Based on that, we concluded that if success rate is better when we give at least 15 surgeries each residency year, means after 45. So that is the method by we can quantify that at least a resident can get 15 surgeries in 1 year. Thank you very much. These are my references.
Very nice presentation and very good analysis. I have 2 points in one question.
Yes, ma'am.
So you have mentioned first, second, and the third year residents.
Yes.
Did you calculate or find out how many surgeries should be given to the first years, to the second years, and to the third years?
Yes, ma'am. I already mentioned it. 10,
you
15.
mentioned 15, 15,
15
15.
each in each group. 15 to 20, ma'am. We have given 15 to 20 cases for the first year.
No, to have a 100% success.
So for
to be a
anatomical
successful
success,
surgeon.
45. 15 in first year, 15 in second year, and 15 in third year.
And secondly, in your study, there were 24 females and 11 males.
Sir,
did you study that females' results were better
no,
than the
ma'am.
males?
It's not like that. Just because we have more resident, even my first year resident, all 9s are females. I can't do so.
Okay. Thank you. Thank you. Very nice.
Thank you, ma'am.